It is just now 3 o'clock. So if you want, you're welcome to start, Lisa. If you want to give it a moment longer to see if we have anyone else join us, it's completely up to you.
Okay, well, let's just give them another, let's say 2 minutes and just see if at least Dr. Stone pops in, because I was expecting her. A
Yes,
lot of
ma'am.
these questions on here are things that have been burning for her, so.
Well, since we have a quorum, Lisa, I move that we approve the April minutes.
Yes, we absolutely can do that. So, and who was that that's just spoke? Does D. Okay. So, so if we want to go ahead and approve the minutes for April, and I already have a first from D. Polita and do I have a second?
Friendly reminder, your camera must be on to vote.
Oh, huh. Hang on, let me do that. Sorry, I forget. Can you see me?
Yes.
Yes, ma'am. April, can you also
me.
turn your camera on?
I'll intermittently have my camera on and off, but I can't turn it on right now. I'm sorry. I'm
Okay,
in the care area.
I understand. We will need, it looks like Dr. Stone is logging in. So as long as she can turn her camera on, we have 3 voting members.
Whenever I vote, I can run to the bathroom or hide somewhere.
Yes, ma'am. And I completely understand. That just keeps us covered.
Yep.
Okay. It looks like Dr. Stone, I'm assuming that's Eva, is on.
Yes. Yep,
Okay.
that's her. Yep. Okay. All righty. So if we can have somebody visual that can give me a second, we'll approve the minutes from April.
I'll second it.
Yay! How you doing? Thanks for joining. So we've got 4 out of 5. That's pretty good. Okay. All right. Wonderful. All right. Thank you very, very much. And as we all know, we took a little summer break last time. So we did not meet, say April, May, June. And so here we are in August 10th. I hope this finds everybody well. We really were kind of caught up on old business. What we had was new business that carried over on the agenda because we didn't meet. Some of these were questions that Eva Stone had brought forward, Dr. Stone had brought forward, wanting to see addressed. Great questions. We all want to see them addressed. So if it's all right with the team, we will go ahead and move through the agenda. So the first question is, with the end of the pandemic emergency, we would like to update from the cabinet on the Medicaid unwinding and how things are going. We talked a lot when we got together the last time about all the plans they had to make sure that nobody got lost in the shuffle of transition as benefits came to an end for some people. So we're wanting to see how things are going, where we are with people losing their coverage. I know there's a lot of concern about maternal health and child health from this particular group, a vantage point, but we care about all Kentuckians, of course. But if we could hear from the group with how that's going, that would be great.
Lisa, I'm scrolling through to see who's on from DMS that might be able to answer that.
Okay.
If one of the MCOs has any information they would like to provide, they're welcome to speak while I scroll through the list really quick.
We did have some great presentations from them when last we met, because I was actually amazed at how diligent everyone was and what robust programs they had planned. So we're eager to hear what you got.
I do know, I think that the admin denials, which is sorry, this is Stuart on WellCare. That the procedural denials, basically somebody has to do something but hasn't done it, was higher than anticipated. However, on a recent call with other well-care markets. I learned that 12 different states, I believe it is, CMS has shut down the state because they're not doing it well. Kentucky's not one of those states, but those other states have been shut down on that. They've had to stop basically because they haven't been doing it in a compliant, well enough to satisfy CMS, but that's not the case with Kentucky.
Okay.
And I know DMS has been extremely aggressive, a whole lot of outreach. I mean, ongoing outreach to members and phone calls. I mean, it's a very, very, very high, intense campaign that DMS.
Yeah. Yeah, I know the plans, because when we met last time in April, I think we all were pleasantly surprised and impressed by the aggressive plan that was there. So when you say that to me, did you say Stuart? I'm sorry.
Yes, yes.
Okay, so Stuart, when you say that to me, you mean people are reaching out to keep their coverage, but they're not completing the process correctly?
Yeah, so procedural denial is basically somebody's been notified, a member, that they need to take act, they need to do something, and they're not doing it.
Gotcha. Okay.
To basically, prove that they're eligible and they're not doing it.
Okay. And we don't know what, maybe DMS does know what those reasons. I mean, there may be reasons that we've identified. Maybe there's because I know there were pre-planned ways to address issues with language barriers and access barriers, and
some are people that probably realize they don't qualify. It's just, from what the records they have,
right.
they need to reattest, but they realize, well, I've got a job or whatever. I make too much now, and they're just not bothering to do it.
That makes sense.
Because they're probably not eligible.
Okay. All right. Well, thank you. That's very helpful.
Hi, this is Dr. Terrio with Medicaid, and Stuart's right, up to a third to 33 to 40% of people that are not following through have a different insurance. So either they've gone on to Medicare, or they have a commercial plan. So it's not as, I guess, shockingly horrible as
it sounds on the surface.
Yeah.
Lisa,
Yes.
this is Victoria with Anthem Medicaid. I can speak to our efforts as it relates to redeterminations. We do have, as many MCOs, I believe, probably have something similar, but extensive education campaigns going, from updating the address to making sure they take those next steps to renew, and then also targeted disenrollment outreach up to 90 days. We're also actively leveraging our community partnerships to assist members and the community with this process. Anthem Medicaid has diaper pantries, health and hygiene closets, and community resource rooms across the state. So we have individuals actively going there on a monthly basis to try to make sure that members have a place to go. If they have questions, the community can ask questions, and we're actively providing and distributing those resources. In addition, we're working with the CBOs to make sure we are providing renewal lunch and learns and pop-up outreach, such as like the state fair. We're going to be there educating on renewals. And then also just communicating with providers and community partners and members around keeping them up to date through our newsletter outreach, and working internally with our teams to make sure individuals don't fall through the gaps during this time. We to date have sent out over 50,000 communication efforts to our members. And we are, thankfully, I'm proud to say that we are seeing a 72% engagement rate. SMS is leading in engagement for Anthem Medicaid. So
That's awesome. Thank you. Did you find anyone else, Aaron, for us?
I didn't. Kelly was kind enough to reach out to Veronica Judy Cecil, who is actually hopping on a meeting with CMS regarding unwinding, so she can't join us.
Okay.
But she asked us to let you guys know that there is a stakeholders meeting. I believe she said next Thursday. So I'll email you guys the link to that. She said there's a lot of wonderful information about unwinding, and she encourages, excuse me, everyone who can to attend. So I will send that in a follow-up email after the meeting.
That's wonderful. Thank you very,
You're
very much.
welcome.
Okay, so then we'll go ahead with that unless anyone else has anything else they want to add to that topic. No, okay. So
No,
then
just-
next on the
At least I
agenda.
will say, just to echo the thanks for all the work that's happening.
Yeah, a lot. It is impressive. I mean, a lot of good effort's been made. And to know that Kentucky has managed to stay off the no-no list is also very encouraging. Yay, okay. So good job there, guys. CMS just issued new guidance for delivering school-based Medicaid services. We request that DMS, which may be difficult since they're not going to be able to join us, discuss their upcoming work around the guidelines and any implications for nursing. Is that something we're not going to be able to address at this meeting? Will this be a holdover?
I
We
believe I
should be
saw
able to.
Erica. Oh,
Yes.
I'm sorry, Erica. There you are.
Hi, good afternoon. I'm Erica Jones. I am the manager over maternal and child health, which includes the school-based services. And in reference to the bullet point on the agenda, in May of this year, CMS did release the Delivering Service in School-Based Settings, a comprehensive guide to Medicaid services and administrative claiming. It's the first comprehensive guide for school-based services that Medicaid has released since 1997. So it has been met with some eager anticipation to get into it. In addition to the written guide, there's also a technical assistance center that's available to states and school districts. The goals of the new guide are to further explain how payments can be made for school-based services, including examples from various states. Also to simplify billing, which will assist rural and small communities where access to healthcare may be challenging, and also enrolling qualified healthcare providers to offer services in the school setting. And that's with that acknowledgement that some schools are not able to hire all of the staff that would be needed. We're also awaiting further guidance regarding a proposed rule to streamline consent provisions under the IDEA. That would diminish some of the red tape for school districts, but it would not interfere with FERPA and parental consents. And DMS is also hiring a Medicaid specialist. We are in the final steps of getting that person hired on, and they will be coordinating the school-based services and should be a resource for all of our school districts.
That's wonderful news.
Thank
To
you,
have
Erica.
somebody just in charge of that is gives you the focus that I think folks like Dr. Stone are looking for, right?
Yes, and you're very welcome. And if there are any specific details that you're wanting us to present, we can do that at the next meeting. Once we have that staff in place and also have a chance to dig through those 184 pages of new guidance.
My, they never make it easy, do they?
Much appreciated.
184 pages, just a little light reading. And then they wonder why people have so many questions. Thank goodness there's so many talented, well-educated, well-informed individuals working on this. We appreciate everybody that works on these items. It makes a difference in the lives of so many Kentuckians. Health disparities for Black mothers. Dr. Thoreau, I saw, is on the meeting. You were going to come back to us with some information, and you weren't able to make the April meeting.
That's right. And I'm glad you left me on the agenda and didn't just forget about me.
No, ma'am.
And Erin, can you let me share my screen?
Yes, ma'am. Or I have your presentation pulled up that we sent out in June, whichever's easiest.
Oh, I updated it a little bit.
Absolutely.
When I looked at it, it's like, oh my gosh, That seems like a really long time ago. So I added a few little things.
You should be a co-host, ma'am.
Thank you. This will stop you. Yeah. And- Can you guys see it?
Yes, I can.
Okay. Yep. It's not very long. So if I remember right, this was mainly to talk about health disparities for Black mothers as far as maternal health goes. And so I tried to focus on that. And just a little definition, because they have so many different ones when you're talking about maternal deaths. Pregnancy-related deaths are the deaths that occur because they have something to do with the pregnancy. So they presumably would not have occurred if the mom wasn't pregnant, versus pregnancy-associated deaths, where the mom died either while she was pregnant or within a year of being pregnant from some cause that had nothing to do with the pregnancy, like earthquake or something. And so when you see the different numbers, you really have to make sure, or the rates, you have to, look and say, okay, is this pregnancy related or is this pregnancy associated? But when we focus down primarily on the pregnancy related deaths, so these people died because they were pregnant, there were more than 1,200 deaths in 2021. And this was one of the things I went to see if they updated it, because I thought, that's a long time ago, but unfortunately they have not updated that. And this came from, national sources. So it takes them, more than a year to kind of get the data, but that's an enormous amount of pregnancy related deaths.
Yes.
Now getting into Kentucky specifically, on our census, we had 87.5% of our population is white and 8.5% Black. And the majority of women that give birth are in metropolitan areas with access to, those tertiary care centers. Yet our pregnancy related deaths are much higher for Black mothers in Kentucky than white moms. Now this follows the national numbers, but it doesn't make any sense because there is access to care. So you can't blame access on these deaths. Oh, and that's my little definition. So when we looked at, this is from our maternal mortality review report that comes out every year. And this is actually the 2022 report. And we looked at maternal deaths from any cause. So any cause, the rate of death for Black women was double the rate of death for white women in Kentucky. So 230.4 per 100,000 live births for Black women and 114.2 per 1,000 live births for white women. So an enormous disparity there. Then when we looked at pregnancy related deaths, so these numbers are much smaller than the all-cause deaths, but the pregnancy related deaths were even more than double higher in Black women compared to white women, which is horrible. So 40.2 per 100,000 versus 13.1 per 100,000. And again, these are Kentucky numbers. So when you're looking at those pregnancy related deaths, why are people dying? And this is from the CDC. So I just circled the highest. If you look at the red circle on the slide, 22.7% of the deaths are caused by mental health conditions, and that is total out of every pregnancy related death. But when you when you look at Black women, only 7% are due to mental health conditions. The big things that Black women are dying from are cardiac and coronary conditions, cardiomyopathies. And then when you look at the other ones that are highest, embolisms and hemorrhage. But when you look at white women, when you break it down, the highest is still mental health conditions. So, so that, you know, that's a big problem, I think, because what we do in the state to address the problems for Black women are going to be different than what we do for white women. And it appears that for Black women, there's a whole lot of cardiac conditions or hemorrhage, things like that, that need to be addressed. So our all-cause deaths are increasing steadily. And this is what, 140.9 in 2018. We'll have to update that number, but you can just see it just keeps going up. And then from national numbers, this is over time as well. And it's the mortality rates broken down by Black, non-Hispanic, white, and Hispanic. And I can't point to it, but the highest cluster are the different or the highest rates of deaths are the African-American women in every year from 2018 to 2021. And then, of course, if you are having problems with pregnancy, you know, what's the other part of that dyad is the baby. And so Black women also have much higher rates of preterm births. You know, white is 9.1, Black is 14.4, and also low birth weight. So again, much higher than the rest of the racial breakdown for our Black moms. And I think part of, you know, it's a lot of data and you think, well, what can we do about it? I mean, part of it is defining the data and looking at it, and then you can try to piecemeal, you know, what are we going to do? What are some things we can do? Because, and this is just personally for me, because a lot of our Black moms are in the metropolitan areas with those tertiary care hospitals, and access to care is there, and it's the same doctors and the same, you know, staff and everybody, you know, the same system taking care of these moms. I think it kind of boils down to the human factor is what the difference is in you know, the white moms and the Black moms. And so we have to maybe address things like bias training, implicit bias training, and things like that to try and get some of this addressed. Yep, and that's all I have. I shall stop sharing.
Thank you. That was very informative and sad. The numbers are just disturbing.
Yep, I'm sorry.
Yeah, we all are. But it's interesting you bring up implicit bias, because there is education through K&A available on implicit bias. It's very well done, and that is available. But to make an effort to get that statewide, it needs to be done. Yeah, absolutely. All levels of caregivers. So thank you very, very much. Any questions for Dr. Thoreau? Any comments?
Just a question. Thank you, Dr. Thoreau, because that was, I mean, that was a great presentation. It's heart-wrenching, but it's great. And I'm assuming this is a yes, but I know that there's been a lot of work done on your all's end for equity across the state. And can you just tell us how this is folded into the equity work that you're doing? Can you tell us a little bit about, because this is so disturbing in areas where, you know, metropolitan areas especially, there has been so much education and awareness done that we just aren't making gains.
I think we just have to do more. I think, honestly, I think we're still in the stage of you know, a lot of people don't believe racism exists. And, you know, so you have to kind of get over that barrier before you can do other things to address the issue. So I think we just have to keep trying on all fronts, keep it in the front of what we're doing, you know, when we're working on projects, make sure that we are, you know, considering, you know, race and ethnicity when we create projects and things like that. It has to be part of everything we do.
Thank you.
Anyone else? Well, that was wonderful, Dr. Thoreau. Thank you very, very much. We appreciate the information. And of course, Erin, we're going to make sure that that's PowerPoint shared with the team.
Yes, ma'am.
Okay, perfect. Perfect. Okay. All right, then. We're moving along rather quickly. The state plan was amended to allow billing for community health workers. We'd like an update on that. And there was a lot of robust conversation about that, especially looking at ARNPs and just wondering where those conversations are, or where we are with any of that.
Jonathan did drop some information in the chat that I've copied to send to you in an email as well. But is there anyone on that would like to give an update?
Well, this is Angie Parker. I am the Director of Quality and Population Health within the Department for Medicaid Services. The community health worker did, for the providers to be able to bill, did start July 1st. The information regarding an FAQ is on our website. And I do have we've already done some adjustments to that, but as Jonathan has put in the chat regarding the regulation, that will probably be a benefit for you all as well.
Thank you. I just now saw that link, and that'll be sent out to everyone as well. What Erin just stated. Thank you. That'll be very helpful. Team, any questions?
Just a thanks to everybody.
Very much so. Okay, do we have any reports from our MCOs that are on the call?
This is Stuart. I don't have any reports, but earlier, we're talking about racial equity, and there is a concerted effort, all MCOs and DMS. We kind of have a collaborative work group regarding that, and regarding tools that we all have to address that. And so it definitely is something that we all are, planning and developing, and obviously it's a critical need. Probably should have been better, I guess, in the past, but it is definitely a point of emphasis, with all the MCOs and DMS, and there is a collaborative work group going on.
That's great. That's great. I didn't know. That's wonderful. Thank you very much, Stuart. Anyone else?
Well, I just want to add to that. I mean, again, this is Angie Parker with Medicaid. A little over a year ago, and the department did a reorganization, and part of that reorganization was the development of Quality and Population Health Division, and within that division is the Equity and Determinants of Health branch. So that's where we have kind of forced the topic. And we are looking at this very holistically, and as Stuart mentioned, that we are working with the MCOs, and we're ensuring that information in contracts and whatever is put out from Medicaid includes equity information and how to ensure that it is part of the conversation.
Mm-hmm. Good, excellent.
This is Jennifer from Aetna Better Health. Just to to add additional information to, managed care and how we're helping to sort of tackle this equity issue. What I think, we've been thinking about these topics for a long time, right? And we know that they exist, but identifying where they exist and to the extent is sort of the first step. But I feel really strongly in what we've tried to do at Aetna is to understand the sort of member perspective as to why these disparities exist, right? We have, DMS has the data, each MCO has data. We can look and see, like Dr. Terrio provided, who is seeking or not seeking services at disparate rates. But the question we all need to be thinking about together is why? Why, what is it about the experience of Black women in the West End? And why is it that although they have access to services, there are still barriers that exist to them receiving those services? So getting the voice of our members in this conversation is really important to me. We're, as an MCO, not always the first round of people that our members want to talk to about these issues, right? We want to be part of the solution. So we've started some community health councils in different areas throughout the state to bring stakeholders together to ask these questions and to get perspective from members, from providers, from community-based organizations. What is it you're seeing in your area as top priority, and what can we all do across industries to try and tackle it, be it food insecurity, housing, and those barriers to receiving the services that DMS allows us to provide. And we feel very grateful to be able to provide to our members. It's there, but how do we get our members to those services? So I think that's just something that I try to impart on whenever we're having these conversations, is identifying the disparity as one piece, but like, what's the why there, and getting our members who are impacted by these inequities is really important.
Hi, this is Stephanie Kuntz with Anthem. To kind of piggyback on that, we have realized that doulas, we had a doula grant in 2022, and we're continuing a doula grant in 2023. In 2022, we focused on women of color in urban areas, and this year we're focusing on the rural area. But I think that having doula services really does help, and our members advocate for themselves and understand the process, understand prenatal care, understand postpartum care and the importance of all that, and making a birth plan that works for that person. So I think that doulas aren't currently covered by Medicaid, but I know quite a few MCOs are trying to weave doula, extra benefits, whether it's through a value benefit or a vendor. But we have seen great outcomes with our doula grants, really low, really great improvements in the birth outcomes, low C-section rates, low preterm birth weights, just really good outcomes, lots of breastfeeding, low postpartum depression. So I really think that doulas can help us play a role in this equity, because they are in the community. They're really boots on the ground. So just kind of a little food for thought there, and what we've seen through our doula grants.
Thank you.
You're welcome.
Hey, this is Suzanne Lewis with United Healthcare, and I would just echo that and I 100% agree with you on the doula services. We also offer doula services for our pregnant members and any of our pregnant members. I have a community health worker on my team who is also a trained doula and works with our members. So, I agree. I think that's part of it. I think there's an education piece. And then more than that, when we look at this from a population health perspective, one of the things that United did earlier this year was, with regards to our maternity program, we implemented a new program for our rising risk population and focused on our BIPOC moms to really look to see what those disparities were, to talk with our moms, to educate, provide doula services, and engage with our members in the community. You know, again, trying to address some of the inequities and disparities for our BIPOC population. So those are some things that we've been doing as well, just this year. And like I said, I think it was like February we rolled that out. So I would agree, but with the doula services, I would also sing their praises. And I think that that is a great option for Kentuckians.
Thank you. Thank you very much. Yeah, doulas provide invaluable service. Anyone else?
Lisa, the only other, this is Suzanne again, the only other thought I had was around, you know, as this is the nursing TAC, I was wondering what are, you know, whether or not we're, what, I don't know if anybody's on from Galen or any of the nursing schools, you know, having more diversity in the workplace and more diversity in healthcare providers for our moms. I think that's huge. And I'm just wondering if we're seeing any effort to recruit more diversity in our nursing students. I'm just thinking along those lines. And I don't know the answer to that. So it's really a question to the group.
Well, now I don't know if April Hester maybe might have something to add to this conversation, but I can tell you from being on the board for KNA, on the board for KNAC, working extensively with different committees within that structure, there is a huge effort being made to look at equity and inclusion and recruitment and what that looks like and how do we make that better.
Okay.
Along with, and that sentiment is shared and is part of the action agenda for both ANA and KNA and many professional organizations across the United States. We realize we have a problem. And we realize that our professional organizations can play a huge role in that. And what I understand from fellow KNA members that are part of the team deans and directors group, which are the nursing schools, the academic world that meets regularly, is that they echo that concern and are making great efforts in recruitment.
Okay.
To try to change so that our population that is giving care reflects the population of those receiving care.
Yeah, that's awesome. That's awesome.
So there is a lot of work going on there, and there is a lot of recognition that we have a long way to go. But there is a lot of effort being made. And I feel like I can be transparent with this group. The political climate can be a little tough.
Yep.
Now,
I was about to mention that as well.
Yeah,
it's a fine line
Lindsay,
that we have to walk
yes.
in the legislative world as well.
Yeah, it's a very difficult time because things like pandemics and healthcare and things that really don't belong in the middle of the political arena have become moving pieces inside the political arena. Yeah. And we all know that there are issues there. Regardless of what your stance is, the fact that there's a great deal of discontent and disagreement adds to this particular problem.
Yeah.
So, and we're all aware of that. And how do we do that judicially?
Right.
And with finesse. That's the other piece that's being worked on.
I just wonder if this group, and again, I don't know that this is the right area, so redirect me if I'm wrong, but I just wonder if, like, you know, again, working with some of the educators in this space in nursing schools to help with promoting and recruiting diversity in the work, you know, in the healthcare field. One of the things that I think, one of the root cause, I think there's a lack of trust in providers. I think people have a lot of past trauma that prevents them from going or seeking care. And I think those are at the root of what of the challenge that we're having with the disparity and in maternal mortality. And I think that, you know, again, if there's a way to promote, encourage, collaborate in the nursing space, especially, you know, nursing schools, recruiting, I'm not really sure where the right place for that is, but, you know, I think that has, you know, getting some of that inequity addressed in the workplace, in the nursing field, could be very valuable and very helpful. And then, of course, you know, I think the nursing educators could probably school me on this as well, but I know we do a lot of trauma-informed care with our staff, and we spend a lot of time on that. And I would assume that they do that in nursing school, but you know, again, it's been a long time since I was in nursing school, y'all.
Right.
Lisa, if I can just add to what Lisa was saying. So nationally, I mean, there's a lot of work happening in Kentucky with the Kentucky Nursing Action Coalition and with the Kentucky Nurses Association. But nationally, the whole Future of Nursing 2020-2030 document with the National Academy of Medicine is around nurses advancing health equity. Yes. And very specifically, maternal child health is addressed, how nurses can improve, and diversity within schools of nursing is addressed. And so colleges have been called on to increase what they're doing and in their efforts of recruitment. And then, of course, part of it is the barriers that exist for folks who are marginalized to access college and to have the same opportunities. And so that work is happening in those areas too. But, you know, there's over 80,000 nurses in Kentucky. And so we could do a lot as far as improving health equity in moving forward with the education of nurses. And for our continuing education this past year, everybody was required to complete training on implicit bias.
Yeah.
I remember that one.
Excellent. And these concerns, of course, are already topics of conversation in the professional organizations, but this conversation will be displayed in the minutes, the report that I give to the KNA, so that they, and I don't think there's ever a wrong place to speak up as far as trying to problem solve what to do about what we know is an existing problem. And your statement about a level of distrust is evidence-based. I mean, it's research-based. We know that that's there, and the roots run very, very deep. And it's going to take a village to make that better, and time. But thank you. A lot of really, really good points.
Stuart with WellCare, I was just going to add something just kind of related, loosely related. There was a bill that was passed, and I think it took effect at the end of June, that created a fund. It was House Bill 200 to address the nursing workforce shortage, where the legislature allocated funds, and then private entities, anybody can donate money to the funds, essentially to create scholarships to give to people to go to nursing school who obviously can't afford it, you know, on their own. So anyway, I mean, that should help. That just went live, I think, at the end of June.
Good point. Thank you. That's a good point. So there's efforts out there. They know we have some distinct needs. Anyone else? This is a great conversation. Oh, all quiet. Okay. So we're 45 minutes in, but we've run through our agenda. And when I ask if there's any more conversation, I got silence. Does that mean we're about at an adjournment time? Really? That quick?
I think we're all depressed now.
It's very possible, Doc. It's very possible. Or overwhelmed with the amount of work we have ahead of us. And it indeed is going to take a village, all of us, all the efforts. I'm very impressed with the MCOs reporting out the efforts they're making to address healthcare inequity and look at racism and bias. Your efforts are applauded, and it's going to take all of us being diligent and steering the course. And some comments that sometimes come up is just to throw this out there is that when you talk about inequity and inequity in healthcare, that it's important to remember that racism isn't just a black-white thing. You know, we look at our gay community, we look at our transgender community, we look at our poor community, our poverty-stricken communities. Racism crosses many, many lines when you look at inequity. And I think often it's viewed as just a black-white thing, and it's which is huge all on its own, but it's certainly not the whole picture. So many lives are affected in so many ways, and these human beings don't get the care they need, and that's a sad thing. Anything from the group? What about our TAC members? Anything you want to discuss? No. Other ladies on the phone? Dee Polito, you still there? Jennifer Wiseman, April Hester?
I'm still here, Lisa. I have nothing more.
Okay, all right.
I'm still here too, and I don't have anything to add.
Okay.
Same here. Same here, Lisa. Thanks for asking.
All right. Well, that was a good, robust call I think we just had today, and I appreciate everybody's willingness to share and talk about this important topic, and for getting back to us on all the agenda items. Greatly appreciated. And we look forward to the report from DMS that is going to be forthcoming, and then all of those links and the PowerPoint from Dr. Thoreau will be coming to us via Aaron in the next couple of days. So very appreciated, guys. So with your permission, I'm going to move to adjourn if I can have a second.
I will second that.
Okay, wonderful. Thank you so much, everyone. Take care.
Thank you all. Have a great rest of the day, everybody.
You
Hope
too.
you're feeling good, Lisa.
Thank you. Bye.
Thank you.